I'll start with doing an introduction of our speaker today, who's one of our hub team, and then we will I'll turn it over to Dr. Root to do a brief mindfulness, and then we'll have everyone sort of introduce themselves in the chat, and we'll get started with the didactic. And then at about right on the top of the hour, we'll shift over into our case-based learning. Anyone who's able to turn their cameras on today, we always love to see that and build community, and we realize it's not possible for everyone. If you can turn it on for the second part, that's definitely when we're interacting. That's a great time. Well, it's always a great time, but we really love that if possible. But who we have today to talk to us is our hub team member, Dr. Lindsay Brewitt, who is a licensed clinical psychologist who consults with families and providers of children and adolescents. Dr. Brewitt's areas of expertise include evidence-based treatment and assessment of eating disorders, anxiety, depression, disruptive behavior, trauma, and OCD. She highly values the importance of including family when supporting young people and specializes in parent-based interventions. Dr. Brewitt has extensive experience providing care and consultation across the socioeconomic spectrum and is committed to continually striving to reduce healthcare disparities caused by systematic oppression. She loves partnering with providers and families to support mental health. So with that, I'll turn it over to Dr. Brewitt to lead us in a brief mindfulness and then give us her didactic.
Thank you so much, Dr. Hack, and thank you all for being here today. It's great to have you. So for our mindfulness today, I invite you, if you're able, to sit back or relax where you're standing, putting down any objects you might be holding if you're able to. And we're just going to take about a minute and focus on our breath. So I invite you to observe your breath. You might choose a spot at which your breath is most apparent to you. Sometimes that's a space under your nose or your chest rising and falling. Just taking a moment to notice your inhales and your exhales. No need to change your breath in any way. Just observe what seems to be happening with it today. And we'll take a moment and do that. If your attention is wandering, you can bring it back to your breath. Okay. Thank you all for participating in that mindfulness activity. You can go ahead and rejoin us if you're able to. As Lauren said, we'd love to see folks on video if possible, and we totally understand that that is not always possible. And I'm going to get my slide share going here. All right. Does this look okay, Dr. Hack? Okay, thank you, thank you. All righty, so welcome today. So I'm going to be talking about responding to disordered eating in school settings. A couple of things before we get started. So we were formerly called CAP. We are now called CalMAP. Folks that have been joining every month probably know that by now. We offer personalized consultation with child psychiatrist, psychologist, and a social worker. And so if that might be helpful to you or somebody on your team, please give us a call or request a consult online. And then finally, we want to introduce the fact that we have a monthly webinar series recording, and that can offer free CME and CE credit or whatever several types of continuing education. And there is a link there if you'd like to sign up. You can also find that via our website. So we invite you to take advantage of that service. Our financial disclosures, we don't have any commercial interest to disclose. We're grateful to our funders for supporting our program. All right, so today we're going to be talking about disordered eating. We're going to be dispelling some myths. We're going to be talking about ways to avoid inadvertently promoting diet culture or disordered eating in schools. Eating disorders are severe. So of the psychiatric illnesses, they're the second leading cause of death. They were just recently surpassed by opioid use disorder. So they're really serious business. Within eating disorders, deaths, about 2/5 of the deaths occur via suicide and about 1/5 via cardiac complications. There are a number of myths surrounding eating disorders. We know that eating disorders can actually present in any weight across the spectrum. There's sort of an unfortunate myth that eating disorders only or primarily occur amongst thin, white, upper middle class women. We know that that's absolutely not true. And in fact, when we look at folks who have eating disorders, only about 6% of them are in body weights that would be considered in the low weight range compared to the general population. So 6%, that's a really small percentage of folks with eating disorders. Most folks with eating disorders are in bodies that would fall in the average, high weight or obese categories, according to the CDC. We know that people don't choose to have eating disorders. We're learning more and more about genetic contributions to eating disorders. So we know that they're really biologically based, genetically based, brain-based illnesses. We don't need to rely on a patient's desire or willingness to recover, and we'll talk more about that in a little while. We have an unfortunate, many folks here are probably familiar with this because many of you may be adjacent to the mental health field or sort of familiar with this idea, but we have an unfortunate tradition in our mental health field where we have blamed parents, particularly mothers, for mental health disorders. That happened with schizophrenia, it happened with autism. We referred to refrigerator mothers as causing those illnesses. We know super clearly now that that's absolutely not true. Unfortunately, the field of eating disorders, or sort of our cultural understanding of eating disorders, is taking longer to catch up. And so it's still, the myth is sort of still out there that families cause eating disorders, particularly mothers, that it must be based on the way they're raising their kids. We know that the literature that supported that was problematic. It was mostly cross-sectional. We also know that when there's a chronic illness or a critical illness in a family, the family reorganizes around that illness, of course, because it brings a tremendous amount of stress to the family. So if we're looking at a family cross-sectionally and they're supporting a young person with an eating disorder, they are going to look like they're really struggling. And that's because they are. But that doesn't mean that those struggles were present prior to the eating disorder or caused the eating disorder. We also know that we really need, when caregivers are available, we really need them to be active participants in treatment and even guide treatment in some regards. And when we as humans are feeling really guilty or ashamed, we're typically not able to act very effectively. So that's sort of another reason that we want to really be mindful of the way in which we're thinking about families. And finally, full recovery is possible. So I hear from many people when I tell people that I work with eating disorders, many people say like, oh man, that must be really tough. Like, isn't it true that you can't ever actually recover from an eating disorder? And what I say is no, actually, you know, that's been the myth out there, but it is possible for folks to make a full recovery. And we absolutely expect that, especially for our adolescents who are still young, their brains are still malleable. I'm just going to do one adjustment here on my oops. Screen share a little bit messed up. Lauren, can you still see my slides?
Yes.
Okay. Questions, why can't I? Give me 1 moment. All right. Thank you for your patience. Okay, so when we think about eating disorders, what are we even talking about? So these are the typical disorders that we see in our clinic. I think the good news is that in school settings or primary care settings or whatever settings folks are working in here, if they're not specialty eating disorder centers, you don't really need to know exactly what type of eating disorder is in front of you, because as we'll see in a minute, the evidence-based treatments for all of these illnesses are approximately the same. And the ways in which you can support these students are exactly the same. And so you don't need to worry too much, but I just like to put these up here so people sort of know what we're talking about. Okay. We know, as we're talking about thinking about the myths in eating disorders, that it's actually true that eating disorders unfortunately do not discriminate. So they impact folks of every race, ethnicity, gender, sexual orientation, etc. And in fact, certain individuals in these groups are actually at higher risk for eating disorders, and we'll talk more about that in detail. So if you take nothing away from this slide, you don't need to worry about the details of this slide, but I hope what you take away is the idea or the fact that there just aren't that many group differences. When we look at racial and ethnic groups amongst folks diagnosed with eating disorders or experiencing eating disorders, there just aren't that many group differences. However, looking at this point on the right here, there are differences in who is asked about eating disorder symptoms in terms of screening and provided access to evidence-based care, such that folks who are white are more likely to be referred for appropriate treatment, and folks who are in minoritized groups are less likely to be referred. And so it's no surprise to anybody, incredibly important for us to think about the biases that we may be carrying because of our sort of cultural understanding of eating disorders, and make sure that we're staying open to the idea that really anybody can and will, unfortunately, develop an eating disorder. Socioeconomic status is not associated with eating disorders. However, food insecurity is. So folks who have experienced food insecurity are at increased risk for eating disorders. That makes sense when we think about the fact that any sort of dietary restriction, even if it's not purposeful, does present an increased risk for eating disorders. We know that about a third of folks with individuals with eating disorders are boys and men. That's poorly understood. Often folks think that boys and men don't develop eating disorders, or that it's a very, very small percentage, but it's not a non-zero percent. And then finally, eating disorder prevalence is higher amongst sexual and gender minority populations when compared with cisgender heterosexual populations. And that's likely for one of two reasons. One is thinking about the minority stress framework that folks might be familiar with. So the idea that anyone who is minoritized is at higher risk of any mental health concern compared with the general population. The other being that sometimes the way in which somebody's gender or sexuality presents their eating disorder may serve to affirm a particular aspect of their identity. We also know that weight status alone does not indicate whether someone has an eating disorder or even how severe their eating disorder is. The research is pretty clear on this point. When we look at folks who have lost weight, so might meet criteria for anorexia or atypical anorexia nervosa, when we compare their medical complications and psychological complications, medical complications across those two groups are exactly the same, meaning sort of regardless of where somebody's weight gets to at their lowest point, it's the degree of weight loss that they've experienced that actually indicates severity from a medical perspective. And actually, psychological concerns tend to be higher when we look at folks in higher weight bodies, and that's probably because of the stress and stigma that they experience. Okay, so you're all busy people, you work in very busy settings. It's hard to kind of do a full assessment if you're worried about a student or somebody in your care. These are 4 evidence-based questions that have been identified to be sufficiently to basically catch eating disorders. So these have been looked at in primary care, but I think they're reasonable to use in schools as well if you're somebody who's in a position where you might be asked to check in with a student or assess how they're doing. And so it can be helpful to add these to kind of your bag of tricks when you're meeting with students. I recognize that not all of you are in positions where it might be appropriate to assess for eating disorder, of course. Okay, so I wonder if folks can put into the chat, what are some signs and symptoms of eating disorder or potential eating disorder that you might see in your setting that would cause you to be concerned or want to ask more? Poor body image, yeah. Rigid eating patterns, absolutely. Talking about dieting or a lot of exercise, skipping meals. Absolutely. Totally agree. And you can certainly keep those coming if you have other ideas. Thanks so much for putting those into the chat. So thinking about early warning signs, these are many of them. This is not a comprehensive list, but these would be things that if this is coming to your attention, either because you're observing it or the family is sharing their concerns, we would want to dig a little deeper and maybe talk more with the student or with the family or consider a referral to the pediatrician or to a specialty eating disorders clinic for assessment. We'll talk more about that at the end. I want to point out a couple of things. So one is becoming vegetarian and vegan. Obviously, people become vegetarian and vegan at many points in their life for all different reasons, many of which are really good reasons. It is true that this can be associated with the onset of an eating disorder in kind of two directions. So one is that if somebody has developed an eating disorder, they may become vegetarian or vegan after the onset of the eating disorder. And that seems to be probably because it's sort of a culturally sanctioned way to restrict eating or restrict certain foods. It can also go the other way that we've seen young people who become vegetarian and vegan, and that may actually, we know that dietary restriction or not getting enough food can precipitate the onset of an eating disorder in somebody who carries that predisposition. And so that can sometimes kind of contribute to the onset of the eating disorder. So if you're worried about somebody or so you know somebody has an eating disorder and they're talking about becoming vegetarian or vegan, we in our program would really strongly advise against that. And it's something that sort of like piques my interest as something that's important in sort of looking at this overall picture. Okay. If you are in a position where it's appropriate for you to assess for eating disorder, these are the areas that we would recommend assessing. So we're basically looking for what are sort of the cognitive or thought patterns that people are experiencing, what are their behaviors that they're experiencing, diet, exercise, things like that. And then of course, any compensatory behaviors, the most common being vomiting on purpose, we also sometimes will see compensatory fasting. So that would be like somebody saying, you know, I had a really big dinner, I had a binge episode in the evening, and so the next day I tried not to eat until dinner. That would be compensatory fasting. And then if we can get this information, we also want to find out what the caregivers have done to try to help and what has been the youth's response to that. Because it's a really different picture. You know, if a family is worried about their child not gaining weight as appropriate or having lost weight, and then they step in and really provide some supervision and try to make sure their young person is getting enough food and the kid is sort of fine with that and accepts it, then we might not be looking at an eating disorder. However, if the child is really doing a lot to sort of try to prevent themselves from eating, like pushing back on food, getting into arguments, kind of debating, having lots of new preferences that they didn't have before, then we want to kind of have our ears open to any further concerns. I want to also point out this note in the lower right corner here. So with our diagnostic system, folks don't need to be stating an explicit desire to lose weight or explicit body image concerns in order to meet criteria for an eating disorder. It's sort of enough for them to be pushing back against food, basically engaging in behaviors that are preventing weight gain or preventing nutritional intake. Okay, so you all work with young people, and so you're very aware of the fact that it's often sort of a different story. Everybody has a different perception of what's going on when we think about young people's perception of their own behavior, and then caregivers or other adults, PCPs, teachers' perception of behavior. These are just a couple of examples of sort of common things that we hear from patients and caregivers that might differ. And so our job as providers who are in an assessment seat is to kind of take both of these pieces of information, all of these pieces of information, and triangulate them to sort of arrive at what we think is going on. In this case, we're typically going to put more stock in what the caregiver is saying, given that the very nature of the eating disorder often makes it hard for individuals to have sort of a solid assessment of what's going on with regard to nutrition and exercise. And that's no fault of the person experiencing it. It's just the way that malnutrition impacts the brain. Okay, so what do you do if you're concerned? These are some recommendations that we have, and I'd love for folks to put into the chat if they have, had this experience before, could imagine having it, and they might have ideas about what they might do if they're concerned about a student with an eating disorder. We'd love to hear about it. So one is to talk with the student, and if it's appropriate for you to speak with the family, that would be a great idea as well. And just sort of using that observe and describe. So, I've noticed that Sarah has been throwing away her lunch every day for the past few weeks, and I'm concerned. She's not in trouble, but I just wanted to call and check in on how she's been doing at home. You can also provide resources, and I'll point you to those in a later slide here. Ideally, if there's concern about a potential eating disorder, the first step that we would recommend would be a checkup with their PCP. That person may monitor or refer to specialty eating disorders treatment. They also can consult with us at CalMAP. We're very happy to talk with PCPs, and we do that regularly. I have received in the clinic that I run some direct referrals from schools for eating disorders treatment. So we're very happy to take those referrals for individuals whose insurance is covered by the programs that we're associated with at UCSF. And then following up. So, if you were concerned about Sarah and you spoke with Sarah or her parents, I would recommend in a few weeks that you check in with them. A few weeks ago, we talked about going to your PCP. Were you able to get an appointment? Can I help you make that call? If not. We know that psychological eating disorder symptoms, so things like body image concern, worry about weight and shape, kind of rigidity around food, those symptoms are heavily influenced by malnutrition. So we know that as folks begin to get more nutrition and rest and their brain begins to recover, that these psychological symptoms actually get much better on their own with kind of little need for intervention besides nutrition. Sometimes intervention is needed, and we certainly provide that when it is. But it's really important to keep in mind that it is unfortunately not possible to sort of talk somebody out of an eating disorder when they're at low weight for their own growth trajectory. We really need to provide them with nutritional support and rest. Okay, so I mentioned at the beginning that all evidence-based treatment for eating disorder kind of revolve around the same set of treatment goals, which again is really nice because we don't have to, in primary care, school settings, we don't need to worry about what type of eating disorder is going on. Early treatment goals include weight restoration or stabilization. So anybody who's fallen off their growth curve, kind of regardless of where their weight is now, we want to get them back onto their own personal growth curve. We know that individuals come in all shapes and sizes, and that's how it should be. And bodies work best when they are in the growth curve range that they have historically tracked in. We also want to work on normalization of eating patterns. So that means 3 meals a day and some snacks. If an individual is needing weight gain, we recommend 3 meals a day and 3 snacks. If they don't need weight gain, 1 or 2 snacks might be okay. We want to support people to be eating at least every 3 to 4 hours because going for longer than that without eating sets people up for binge episodes. We want to be helping to reduce binge eating, compensatory behaviors like vomiting, fasting, things like that. And then later in treatment, once growth is normalized, nutrition and behaviors are normalized, we can address weight and shape concerns, body acceptance, things like that. If the person that you're supporting is really having a difficult time with sort of the cognitive symptoms of the eating disorder, so maybe talking a lot about their body image concerns or things like that, we recommend redirection from that. So validation, I can see that this is really distressing to you. I'm so sorry you're experiencing that. Right now, I know the most important thing that your body needs is consistent nutrition. So let me help you focus on that. We can also help to, well, we'll get to that in a moment, actually. Okay, we've talked about this. Okay, so we know that the realities of our healthcare system make it pretty hard to connect people to evidence-based treatment. And we know that even when it is possible that you can find a treatment provider who's in network with somebody's insurance, they may have to wait quite a long time. And so these are some sort of tips and tricks for things that you can do in the interim. Again, if you're in kind of a provider support or counselor role, that we would recommend. So one is motivational interviewing about the way in which the eating disorder is getting in the way. So this is an example question you might ask about, what ways is this impacting your relationship with your friends or your family, if at all? Tell me more about that. Just sort of eliciting any sort of change talk. I imagine many folks in this virtual room have experience with MI. Another is general coping skills. We want to really focus on active coping. So things like distraction, deep breathing, rather than more passive techniques like reading or quiet mindfulness. The eating disorder thoughts, cognitions that people experience are generally going to be too powerful to sort of for these quieter techniques to stand up to them. So I often will give out like distress tolerance skill lists and recommend that individuals, I'll say to young people, what's the most difficult part? Is it before, during, or after meals? It's after meals. Okay, thank you so much for telling me that. Here's a list of all sorts of techniques to distract yourself. Can you try for the next week using one of these skills every night after dinner? And then meet with them, see how it went. You can sort of troubleshoot from there. And then reinforce any small changes. So, that's really awesome that you added cheese back to your sandwich this week. We know your body needs all the nutrition that it can get. Well done. Okay, and then finally, some tips in general. So I would recommend thinking about these tips with all of your students, not just with individuals who might have experience eating disorder, might be at risk for eating disorder. I have just generally at this point in my life stopped commenting on people's appearances for the most part because it can just be a bit of a trap. So particularly maybe as folks are engaged in the weight gain process, we often my patients will come in and say like, oh, my provider, somebody in my community said, you're looking so much better. And of course, that person is trying to be supportive and trying to reinforce their progress and is super well-meaning, but the individual might hear it, the eating disorder may hear it as you've gained a ton of weight, you look really different. And so in general, I just try to avoid commenting on appearance. I want to be careful not to collude with the eating disorder. And what I mean by that is if somebody says to me, like, there's no way I'm going to eat pasta. Like it's a terrible food. Like it's so scary. I'm never going to do that. I want to be careful to validate the emotion, but not that particular behavior. So I might say like, oh man, it sounds like you're experiencing a lot of distress around this food that you used to really like. I'm not going to say like, yeah, I've heard pasta isn't that healthy. Maybe you should avoid it. We also want to avoid shame. So you're all super probably on board with this because you work on supporting young people all the time who might be disclosing difficult things to you, but it can be really hard for folks to talk about things like binge episodes or compensatory behaviors like vomiting. And so we want to really receive those things from a very open place, sending them the message that we want to hear and support them, and we're able to do so. And then finally, if adolescents are in evidence-based eating disorder treatment, it's important to note that they may not like their eating disorder therapist very much. I have to have a very thick skin as an eating disorder therapist because my job is to push back against the eating disorder and support the healthy part of that individual. And particularly at the beginning of treatment, that can be very uncomfortable for the eating disorder. And so if you're hearing that, of course, if you're hearing anything concerning about treatment, you should act on that. But if the young person is just saying things like, I really don't like treatment, like it's such a drag, that's pretty normal, unfortunately. Okay, I'm gonna stop my share and turn it back over to Dr. Hack.
Perfect timing. Thank you, Dr. Brewitt.